So it's been fascinating to hear the prior panels on the person journey mapping. Good clarification there. This panel is going to focus on the healthcare workforce. We're particularly interested, of course, in how the workforce has fared during the pandemic, but we understand that many of the pressures are really endemic to the system that we have and have been building for quite some time. So we have three terrific experts with us today to talk about, and I might just outline first sort of the progression. So we're going to talk first a bit about the drivers of the problem. Second, we're going to talk about some of the ideas at an organizational level of ways to address these drivers and reduce burnout. And then lastly, the sort of broader context of policy and payment reform that might help organizations do the right thing and do right by their healthcare workforce. So we have here, first, Gay Landstrom, who is an RN PhD and the Senior Vice President and Chief Nursing Officer at Trinity Health. And we were just talking about some of the interesting reorganization of their governance that they've done in relation to healthcare burnout and other kinds of challenges, which I'm really excited to talk more about. Second, we have Dr. Atul Grover, who is the Executive Director of the Association of Medical Colleges' new Research and Action Institute. And lastly, and not least, we have Dr. Kedar Mate, who's the President and CEO of the Institute for Healthcare Improvement, better known as IHI. Very good.
Thank you.
So, I'd like to begin with the drivers. So rather than describing the magnitude of the problem, which I think we're all pretty familiar with, what is causing the problem? What are the major drivers that you think are driving people out of healthcare, turnover, burnout, depression, other kinds of symptoms? What are the drivers that you see in your organization?
Well, I'm happy to jump in. We've been trying to diagnose the problem, so our solutions really match that. Unfortunately, it's not a simple answer. It's not a single factor that is affecting our workforce. And while I may speak about nursing and other allied health, it affects my colleagues, physicians as well. Similar kinds of drivers. This is in no particular order, but our workplaces have become very challenging. Patients are sicker. They just are. They're dealing with multiple conditions all at the same time. And while that has been true for a while, patients used to come to us with 2 or 3 illnesses, and now we're talking about blending together care for 7, 8, 9 kinds of conditions that all require some creative problem solving. So the work is hard and it's challenging. It's also, our workplaces have become unsafe. And so people come to work not sure that they won't face threat, whether that is emotional threat or that is physical threat. And it's not just in emergency rooms, which we've seen for a number of years. It's now in all areas of the hospital. It's in ambulatory clinics. Home care nursing is something I'm very concerned about. Home care nurses are going alone into a setting and they don't know what they're going to face. So that kind of anxiety and fear about what you will face and what you need to deal with is something that they're all dealing with. I think during the pandemic, this was true before, as you said, these issues have been emerging, but it became even more acute during the pandemic that so many of our colleagues are dealing with not only child care issues, and some of the volatility there, some of the lack of affordable child care, but they're also dealing with parent issues at the same time. And so people want to come to work and bring their very best to patient care, and they're worried about all kinds of things at home. And that has led to a demand and a need for greater flexibility. They're trying to blend together multiple parts of their lives. I'll stop there. There are more, but I'll let my
you have the privilege of having sort of a bird's eye view of the academic medical centers of the country, as well as your own academic prowess, no doubt, in understanding the broader system, but
Oh, well,
love to hear.
Thank you, Polly. And thanks to the Alliance for pulling this conversation together. So for those of you that are not familiar with the Double AMC, we represent the 157 or so MD granting institutions in the US, a dozen or so in Canada, about 400 major teaching hospitals and health systems. And we also provide a disproportionate amount of care to the underserved. So we're probably about 20% to 25% of the clinical care footprint in the country, but really provide even more than that in terms of charity care, care to Medicaid beneficiaries. We've got highly specialized care like level 1 trauma and transplant. You're talking about 2/3 to 9/10 of all that care. And then even some of the loss leader care that's critically important, we provide about 60 or 65% of all the inpatient psychiatric beds in the nation. So these are big institutions, highly specialized, caring for marginal and medically underserved populations. So but they are large systems and getting larger in many cases. In some cases being part of larger healthcare systems where you've got one or two flagship academic systems, and in other cases you sort of started out with one or two large academic medical centers that are now sort of responsible for the operations of 10, 15 or more acute care hospitals, ranging from critical access to community to the quaternary care that most of you would associate with a place like Mass General or Johns Hopkins or Georgetown or GW, or whichever one we're from. And so it's a kind of a unique perspective and not all-encompassing. But I would say, given that we're engaged in not only the healthcare delivery across the spectrum from sort of community engagement and population health all the way to transplant, but we also do about 2/3 of all the NIH-funded biomedical and health services research in the nation. Those funds go through our faculty at our hospitals, at our medical schools, our schools of nursing and population health. So we're sort of dealing with a macro picture, I think, whether you are in scientific research or clinical care, where the US population and policymakers can legitimately say, look, we got a $4 trillion healthcare system, quit coming to us for more money. And yet we feel like we are resource strapped. And that's not only when it comes to sort of the material resources where 25% of the cost of care in our acute care setting is really supply chain related, but upwards of 55, 60, 65% of our costs are in labor. And so we have a really tough problem in that the sort of, knee-jerk response to the current problem will be add more people. Well, they're already a large part of our costs of delivering high-quality health care in this country. And so I would love to say, let's produce more physicians and advanced practice nurses and PAs and RNs and social workers and pharmacists and medical assistants and clerks, and using AI and get everybody working to the top of their skill set, knowledge, and training. I can't get more of them right now. The cost is prohibitive. So I think, yes, we have to inch forward in terms of making sure we have sufficient human resources in the pipeline to replace what is not only an aging patient population, but an aging clinical workforce, right? So about close to 1/3 of our docs are going to retire in the next 15 to 20 years. We don't have the pipeline to replace them. So I think we do need some investment and prioritization of those human resources to figure out how to train more, but also to figure out how to use them more efficiently. And it is completely reasonable to say, yes, we have waste in the system. Yes, we have a lot of regulatory and compliance burden that we would love to get down. How do we get that down, right? How do we shift some of the resources from regulation, compliance, into supporting our workforce? It is a long-term challenge. I think the other challenge is, really thinking about that workforce over time. trying to get them to do something different is a long process, and we would like to inform that with evidence in terms of how to best care for patients and trying to figure out what patients need, not just what the doctor needs or the nurse needs or whoever else needs in the system. And that's going to be a long haul. I am a radical incrementalist from living in this town for much too long, but it is possible. But it takes small changes along the way, which is not to say we can't do it, but we have to be thoughtful. It is going to take some investment and some reorganization of how we do things.
A radical incrementalist.
Yeah.
I love that term.
So just to summarize where we are so far, we've talked about
Yes.
some of the occupational hazards that have gotten worse because patients are sicker, and because there is a lot of distrust in the community, which is creating violence against healthcare workers. And we've had the argument that there are limited resources, although private equity seems to think that there are enough resources.
Until they go bankrupt and want to be bailed out. Yeah.
At any rate, there are limited resources and they have to be used wisely, more efficient systems of task shifting and teams. And what else from the belly of the beast are we seeing in terms of what people are experiencing? What do the frontline clinicians say is making them sick and want to leave?
Well, I think one thing that's important to think about, so I represent the Institute for Healthcare Improvement. It's a nonprofit organization based in Boston that works on quality and safety and system science around the world. And probably about a decade ago, we started working on what we called joy in work, and which I would argue, and Polly, you and I were talking about this, we were sort of, people kind of laughed at us, I think, at the time on some level of thinking about joy in work, as if healthcare shouldn't have that or something. But the concept, I think, was really challenged vigorously by the community to say that, should healthcare workers have or experience joy in work? And I would argue that the answer to that question is yes, of course. And yet there was a great deal of cynicism around that when we started working on it. Then the pandemic happened. And I think it was everybody sort of started talking about the fact that their workforce was deeply threatened, and the turnover burnout sort of narrative, I think, became part of the ecosystem. And now we have the problem of trying to find ways of staffing our institutions. But we're chasing our tail a little bit on this because we weren't minding the problem 10, 15, 20 years ago when it was already evident that our systems for staff support were grossly underpowered, I would argue, at that time. So I guess the short answer to your question of what's driving this, I think of as in three very quick ways. One is physical safety, frankly. I was surprised to learn, honestly, that healthcare is the most injury-prone industry, period. Higher than mining, higher than nuclear power, higher than submarines in the military, higher than your police force or your fire department, which I think of as very potentially injury-prone fields or risky fields. But healthcare workers actually have the highest per capita physical harm rates of any major American profession. So just think about that for a second. Physical safety has always been, and has been for a number of years, a really big problem for healthcare. Add to that psychological challenges, psychological safety issues. During the pandemic, we issued, there was a lot of attention to PPE and physical safety standards. IHI issued, together with partners that were working on joy and meaning in work, psychological PPE standards that were essentially aimed at trying to protect the mental and psychological health of our clinical workforce as it was enduring, no doubt, one of the biggest challenges of our time. And then lastly, violence. You can't now go a day without picking up a newspaper or turning on the television and seeing something happening in a hospital or health system somewhere in the country, which is pretty alarming to see the kind of situation that we have here. Underpinning all of this, I think, is a sort of deep and continuously eroding trust in our system as a whole. Trust, patients have long, I think, for many decades now, if you look at the data from Gallup and Pew, for many decades, we've seen an eroding public trust in healthcare. We're now seeing the same phenomenon occur with our healthcare workforce. Its trust of the systems in which, our workforce's trust in the systems in which it's working is also being undermined and declining over time. So we have a big challenge on our hands as outlined elsewhere. And there are some, we'll get to this, I know, but there are some promising ideas of what to do about this. But frankly, you can't give what you don't have. And the healthcare workforce needs to have a sense of safety, a sense of security if it's going to be able to provide the kind of caregiving that we ask of our clinical workforce.
So this concept of trust is really fascinating when you think about it in the context of this meeting. Obviously, community trust in healthcare is really important. And the frontline healthcare workforce are essentially the face of the health system. And so I think it makes sense they're in this double bind where they're representing a system that they don't necessarily believe is beneficial to the community. And so I think that's where you get a lot of disassociation, if you will, between sort of what the motives are and the purpose of their work that can be tremendously distressing for those caught in the middle, literally, in the middle between this mega system and the community, having to give sort of their face for the system that they don't believe is helping. So with that, we have sort of some of the more, let's call it this sort of existential crisis of the healthcare system, but you also have psychological safety, physical safety, and resource limitations. How are organizations, I'm gonna try to refine this question. We want to know what works in terms of improving the well-being of the healthcare workforce. But I think it's sort of interesting to think about it in relation to these specific drivers and specifically, sort of what evidence we have that any approach is working. I think there are some approaches that have become ubiquitous and some approaches that are really unusual right now. And so, for example, almost every organization now has a wellness officer. Is that wellness washing or is it really having an effect? What do we know about that? And what are the other ideas that are perhaps less ubiquitous but innovative? I know as Trinity, as a health system, you have a huge playground to experiment and see what works. What are you finding works? And I suppose that the measure is burnout. Maybe you do surveys of worker engagement. And then, of course, turnover is a great measure to understand whether things are working.
We do. So Trinity Health is a large health system. We're a faith-based health system with entities in 26 states. We're in rural areas and we're in urban areas. And so we have a lot of variety in places where we care for patients. I think we looked really objectively at the fact that registered nurses are in really short supply. There may be studies that show that there are lots of licensed nurses, but they are not choosing to practice in direct patient care. They're making other choices. Yep. And so that has resulted in, for instance, in the hospital setting, inpatient units, 24% vacancy of registered nurses. I'm missing one of 4 that I need. In home care, 21%. So we can't take care of all the patients who need home care because we don't have enough registered nurses. We know that across the country, there's been a lot of demand for care and access, yet if you're missing nurses in your emergency room, and we have about 15% vacancy in emergency room, everything starts to back up. You don't have the capacity you need because having a bed is not having a bed staffed with a qualified nurse or nursing team.
So we know that nursing shortages are cyclical and that when the economy is doing well and people's families are all employed, nurses leave, which means that nurses leave when they can. And they have done this for at least 30 years in cycles. What do we know about when the economy is doing well and unemployment is low? How to retain those nurses? Because clearly this is a long-standing problem of the nature of the work.
It is a long-standing problem. I think in the nursing world, we know that there are cycles to shortages. This is very different. This is different and it's deeper. And we are hearing from new graduate nurses or those who are seniors in nursing school ready to graduate that they only can see practicing indirect patient care maybe for a year or 2, not 20 or 30. So that spells a problem further down the road. But to answer your question about what are we doing, we knew that, that the nurses working with us, they do really care. I think they do trust that they've made choices to work with us, and so there is trust in the system, but they're struggling with when you have this kind of shortage, not being able to to know what to expect when you come into work. Will you have your entire team, or will there be shortages that you need to deal with? They needed predictability, and that was part of the anxiety, part of what could lead to burnout. And we heard this from them directly. So we decided we wanted to engage them in helping us to find solutions. And we started innovation units. In a dozen different facilities where nurses helped us really discover what would help us eliminate work that didn't really add any value. Where could other people work with the nurse and really accomplish the safety and the quality that we needed? We did a lot of experimentation for about 9 months, and then we had come across a couple of elements that merged together could create a new care delivery model that would deal with this great shortage of nurses. Try to leverage technology, try to use everything we had to create a different model that would be sustainable, that would really help with that predictability, would help lower anxiety and lead to finding joy in work. And we prototyped it last summer and then began to spread it after we saw the outcomes of that.
And are you relying more on support staff as well as technology? What's the magic ingredient?
So it is a combination of a few things. We knew that our early career nurses, one of the things they told us they were lacking was they didn't have mentors, and they were afraid. It was one of the reasons they couldn't see practicing a long time. But in nursing, we didn't have a lot of roles for senior nurses. If your feet start to give out or your back starts to give out, we lose that skill and knowledge from the workforce. So we wanted to be able to find a way to bring them back in, provide mentoring to these early career nurses, have a predictable, stable model. We wanted to accomplish all of those things. We wanted the patients to feel they had better care. We wanted to maintain or improve on outcomes. And so the model, just in short, is we have a 3-person team. And there is a virtual senior nurse who, through technology, joins the patient in the room on their TV. And works with the bedside RN, who is often early career, and a partner. And depending on the patient population, it could be a nursing assistant partner, it could be an LPN partner. But there are 3 people working together all the time, communicating with one another, available to the patient. Our virtual nurse is available at the push of a button to the patient. So one of the things that frustrated patients waiting for help in a time of shortage, they can push a button and their virtual nurse can answer that question, can allay their fears. So that's what we have done, engaging the staff in finding solutions that are really directed at what they told us were the problems.
Fantastic. We need to design a study around that.
Yeah.
Atul, what are you seeing in terms of innovations and solutions to the problems of burnout?
Well, I think people are trying everything under the sun. Every medical school seems to have aromatherapy available for all of its medical students now. I don't know if that works or not. So research is part of this as well, to say, look, we need to be collecting data around joy. Joy is a hard thing to capture, right? Tate Shannenfeld, who is one of the first chief wellness officers out at Stanford, talks about it more specificity. It's not just the aggregate amount of joy, but the joy to crap ratio in your life. So your joy to crap ratio is, 4 to 1.
Crab or crap?
Joy to crap.
Crap.
With a P.
Just wanted to make sure I heard you
There's
right.
other ways to express the ratio. I'm sticking with one mathematical formula, joy to crap, because I stole it from Tate. But if your crap becomes 80%, right, and the stuff that brought you to the field in the beginning, the stuff that truly brings you joy, whether or not you're paid for it, is only 20%, you got a problem. Now, I don't know how different that is from other professionals in the world, right? I would imagine that if most of us went to work where it was 80% crap, we wouldn't stay there very long if we had a choice.
The behavior is not different, but the prevalence is different.
Well, and the ramifications on others may be very, very different.
True.
Right?
That's true.
And so, which is not to minimize the importance of other workers out there, but to say this is a, direct care. And I think thinking about this in terms of career ladders is critically important, not just for nursing, but for everybody on the healthcare team. and at every level. So at the same time, I'm thinking about, what's a reasonable expectation for a nurse to be out there lifting patients and the crap
Right.
that he or she has to deal with for the bulk of the day. Is that a 10-year thing? Is it a 12-year thing? Is it a 2-year thing?
Right.
How generationally is this changing in terms of people's expectations? And thinking about, it's not just getting the higher end to stick around for a while. And I love the idea of, virtual care in a lot of different ways. But at the lower end, for us as, medical schools and schools of population health and health sciences, we're also thinking about those, community college programs as a pipeline and a ladder into a college program, into a graduate program, if that's what people want. And if not, how do we still help them grow? So I think that's really critical, and collecting the data around it. We're part of a collaborative around clinician burnout with the national academies, with ACGME. I know HI participates, and other large health systems. And one of the early recommendations has been, we got to do the research to figure this out. Again, another expense, another potential,
Another delay.
and another burden on people at the bedside to say, now we want you to report how burnt out you feel.
Career ladders is really, I think, one that healthcare workers at all levels really prioritize. And you see this with labor unions in healthcare. It is sort of beyond the issue of pay, which is obviously, and safety. The issue of career ladders and subsidies for career ladders is very much at the top of the list of demands.
Well, one other thing I'd say before turning over to you is there is still a great deal of stigma attached to mental health distress and burnout. And nowhere is that stigma greater than in the health professions themselves. And I think the state licensing boards, others have tried to make progress in this area, and they want to balance out safety of the patient versus the wellness of the clinician. But we have been incredibly unreasonable in the things that we have asked people to report about themselves as they get their licenses or get those licenses renewed.
And that
we
has
have to
gotten
do
better with the
something.
Lorna Breen Foundation. They've done a good job. I think 21 states have changed.
But it still needs to get better.
It needs to get better.
I'll offer two additional things. One is that I don't think we can pay our way out of this problem. Right? I don't think the only solution to this problem is to hire more or to pay better or otherwise. And I think there's a lot of solutions that look like that right now in the landscape that aren't going to solve the problem of changing the conditions or the underlying conditions within which people are working. The other thing that I would offer, another lesson from Tate's work, who has been a guide to IHI's joy and work efforts, is that joy to crap ratio is not a fixed ratio. It's something that can be modified, changed, altered, and improved. And one of the most powerful reflections, I would say, on what we've been observing when health systems start to work on the things that are causing the problems that people are experiencing every day is that the engagement of the staff in the process of improving their conditions, what Tate calls removing the pebbles from the daily headaches, the pebbles from our shoes, right? When you start to work on removing those pebbles or reducing those barriers to joy or meaning or purpose in our work, it's actually that act alone of committing to improvement is itself meaning-giving and joy-producing and important to the process of healing and reducing the burnout that the staff is experiencing. So I think empowering our people, so to answer your question earlier about what are systems that are being successful at this doing, yes, they might have a wellness program. They might have a yoga, meditation, aromatherapy kind of thing. But by and large, healthcare staff see through those things very, very quickly and see them as superficial Band-Aids trying to gloss over problems. And in fact, the literature now shows that when you do that and that alone, it creates more distrust of leadership, not the opposite effect. So the idea that we need to pursue, I think fundamentally, is actually engaging the frontline care teams in solving the system problems that are causing the headaches in the first place. There's a system out there right now that it was in the New York Times, I won't name the system, but that was preventing patient caregivers, doctors, nurses, et cetera, from providing care to people who had a medical bill that exceeded $4,500, right? So if they had an outstanding debt to the system of more than $4,000, they showed up in the emergency room, you'd have to take care of them in the ER, but you couldn't schedule them for a follow-up appointment, okay? As a provider, that's unconscionable, right? As a provider, I would say that's really problematic. As a nurse, doctor, physical therapist, you're doing something that transgresses my clinical promises and oaths.
Yep.
And that is a direct cause of burnout. When that system ended that practice, which they did, thankfully, you can imagine that was a way in which they were starting to build trust and relationship with their care providers. And they did that because their care providers said, no, thank you. We can't work in a system that's doing this to our patients. I think that's what we need to do more of.
Excellent. So we just have a few minutes before we go to the Q&A. I was asked if you could, so obviously healthcare organizations function in a broader environment where payment and regulation and cultural issues are sort of impinging on everyday life and creating working conditions as well. If there was one thing that you think could either help or currently hinders and therefore should stop, one thing from the external environment that would help organizations do right by their health workforce, what would that be?
One thing.
You can do two if you really can't decide.
I may have to do two. Two are bubbling up. One of the things that I think about a lot as we're trying to work with our staff, let them have voice in telling us where we need to go. They're experts in this, in the problems and the solutions, is to not create new law, new regulation that inhibits innovation. We really do need to, whether we do it incrementally or we do it bigger, we've really got to redesign how everything is working, because it can't be on the backs of our healthcare workforce, whether they're physicians or nurses or allied health. We've got to innovate. And if we create...
So let me interrupt you really quickly. So the economist would say, well, we're giving you value-based payment. You can innovate all you want. You know, we're going to give you a lump sum at the end. Yeah. Why isn't that working? Or is it working?
So if... I think there is a lot of good in value-based care. We all know that we're sort of living in this dual world, and so it's tough to figure out what to do. If you do things in a very value-based way, you actually could hurt yourself financially.
A leg in each canoe.
There's that problem. But what I'm thinking about is regulation, for instance, that might really hardwire old models. That we can't support because we don't have the workforce. We need to leave space for innovation and think about the future, not just what has been in the past. The other thing I just have to throw out, it's an impediment in the entire nursing pipeline of developing even nursing assistants, LPNs, registered nurses, or nurses with advanced degrees, is for one of my staff nurses who may have great talent and potential to be an educator, if they move into academia, they take a pay cut.
Yep.
And it's an impediment. It's a really hard barrier to get over because they're often supporting families and et cetera. We have not built this in a way that will logically help us develop the workforce that's needed.
And that's the bottleneck for production.
That's one of them.
Yeah. Okay. Atul.
So I do think again, incrementally, what could we do right now? I think anything to unbind payment systems from being so tightly tied to doctoral level professionals would be great. It opens you up to some waste and fraud. Everything does, and there's ways around that. But if we can start paying for the work done by medical assistants and LPNs and LVNs and RNs a little more directly, maybe we can get more work done.
That is not incremental. That is very bold.
Well, but it could be done by CMMI on an experimental basis, right? So you could do this in a matter of months administratively. The other thing I would say is, you know, in the long run, you do have this challenge of a foot in each canoe.
Yeah.
We have been talking about radically changing that, going to the other canoe, since at least the 1990s, right? Maybe the 80s if you count DRGs. Whether it's DRGs, HMOs, ACOs, value-based care. We need to keep at that, maybe with a foot less on the pedal, with the accelerator going towards savings to say, can we just get value out of this? Can we make this better for the patients from the patient side of things, as well as from the clinician side. So I think that's, if I had a magic wand, what I would do.
Okay, and last but not least.
I mean, I would say my more radical solution would be to actually get out of the other canoe, right? To get to full value. I mean, I think that in the end, that's going to be a thing that we're going to need to do. I know that's not going to be easy to manage, but at some point, we have to make a commitment, just as we've done with cars, to going electric. So at some point, we're going to have to make a commitment to value and go all in on that. And that should happen. We should set a date and a deadline and just get there. Value by 2035, 2040, whatever you pick it. I don't care what the year
and
is,
Washington
but get going.
will delay that by 5 years, every 5 years, and we will get there. But setting a date is very worthwhile, setting a target.
And then I think the last thing I'll say about all of this is that I fundamentally believe that we need operating systems that actually produce better care environments that allow us to produce joy in work. And that's going to require some kind of measurement. It's very difficult for us up here to talk about what's happening in our landscape because we have really poor understanding of it today. We don't measure trust really systematically in any way. We barely measure. We do have measures of burnout and we have measures of turnover, but they're localized to each individual system and they're collected sporadically and not necessarily consistently. But why wouldn't we add measures of burnout and trust and turnover to our value-based payment models?
Amazing idea. Amazing idea. Get back to a little bit of the process, not just the distal outcomes that we.
Well, if we believe that better caregivers are foundational to better care for patients, then we should be measuring whether or not we're providing.
And we can change those measures over time if we find they're not getting us towards that outcome.
Absolutely.
Those are three. I mean, there are actually 6 ideas there, but I can't remember them all. But I remember 3 that were amazing. I hope somebody's taking notes and can remind us tomorrow what you all proposed. But they were pretty radical. Paying for services that are not just physicians, measuring and the idea of new models that are have mentorship, and really, really fascinating. Okay, we're going to transition now to Q&A. Hi. And I don't know what the mechanism here is, if Alliance staff is going to bring you a microphone, but we'd love to hear from you. And if you could introduce yourself and then direct your question to one or more of the panelists.
Well, directing to one or more of the panels. Can I direct to all?
You can.
That does not count as my question, by the way. My father once told me, when I asked him when I was a kid, Dad, what's your dream job? And he said, son, I do not dream of labor. I am simply paid enough money to deal with the crap of my job. How do we, as policymakers, incentivize the raising of wages for currently lower-end paid care providers like home health professionals who are currently paid, anywhere from $13 to $15 an hour to go into incredibly dangerous situations? We were talking about how our cost of labor is, 60, 70%, I think was the figure that was thrown around. How can we reduce our payment elsewhere to increase that payment? Because I'm a firm believer that if you pay them, they will come.
So I have an answer to that. One, I think healthcare specific is, we do talk about the differences in the U.S. healthcare system compared to others. In one place, we pay everything, we pay more for per unit price for everything. Our prices are high, our wages are high at the high end. At the low end, they're not. But if we could actually get the insurers, which we have laws on the book to do this, to insurers to settle with one universal claim form, right? That would decrease the administrative burden by 10%, 15%, 20%, right, out of 100. Because right now you're dealing with hundreds of different claims forms. The insurers have been pushing against this, but it's something that from a regulatory perspective, you can issue and promulgate those rules today. So I would do that. I think more broadly, for the lower end of the spectrum, I think you have to advocate more generally for a living wage, which means ensuring a floor for all workers. And one way to make sure that you've got the workforce to do that is to actually get new immigration pathways established as well.
But I would say if you're going to add more of the workforce at that level, we also have to learn to trust workforce at that level. So I think one of the challenges will be, even if we had more workforce at that level, which we absolutely quantitatively need, the challenge will be whether or not we will run the risk of burning those individuals out as well, unless we learn to actually listen and trust that level of the workforce, which I don't believe fundamentally healthcare does today. We have trouble listening to and learning from our MAs, we have trouble listening to and learning from our community health workers, and we have trouble listening to and learning from. well, that's true too, but we have trouble listening and learning from this cadre of workforce. And unless we do that, we can hire and pay better, but I don't believe we're going to retain those individuals in the workforce.
And fundamentally, healthcare is very much a team sport. We need to be trusting not just our own disciplines, but everybody else on the team.
Good points. Yes,
Polly, that way.
or
one
Sarah,
way
I'm
over
going to
there.
follow your arrow there. Yes, Clay.
Hi, Clay Marsh from West Virginia University. Really nice discussion. So I am really interested in hearing your guys' thoughts on the more recent op-eds that are appearing in places like the New York Times, where physicians and healthcare workers are talking about the moral challenges that they have with healthcare. And when we think about what motivates cognitive workers, autonomy, mastery, and purpose, but our healthcare system rewards events. And if we pay cognitive workers every time they do something, then they do their job worse, not better. And so I'm curious how you guys incorporate that perspective into your thoughts about burnout and system reform, et cetera.
So it sounds like the issue of trust is as sort of the other side of that
Yeah.
coin, but who wants to start?
I mean,
Yeah.
agree is what I would say to your provocation, agree with above. You know, I have, fundamentally, I believe in, Polly and I and the IHI and GW work on a project together for HRSA in which we've outlined two distinct paths that lead to the kinds of outcomes we're seeing in the workforce. One path is through burnout, and the other path is through what's being described as moral injury, which is defined as essentially the inability to do the things that we were called to do. Right? And again, as I said earlier in my example about the health system that was preventing care to patients that had a medical bill, that goes against our commitments. And when you do that repeatedly, over and over again, you cause a certain kind of cognitive dissonance in the health workforce that is irreconcilable and damaging to the workforce and they believe, frankly. So I think we have to end those kinds of practices, whether it's around medical debt, 100 million Americans in medical debt. If that's not a wake-up call to do something differently in our system, I really don't know what is. But that's crazy. 1 in 3 Americans in debt to a system that we've built in effect. And to add to that, the idea that we might be preventing those individuals from getting the kind of care that they need and want seems unconscionable.
I think Clay, there's an external force here at work, which is people have to figure out a way to pay for health care while always being on the lookout for abuse and fraud, right? So for the government that's setting most of those payment systems, the easiest way for them to do it is to say, well, if you can show me you've done this, I'll pay you this. And every time you do something, I'll pay you again. At the other extreme is a sort of capitated population-based payments, which we rejected in the 90s, we're kind of playing with now. I think we keep moving towards that. I think in the interim, you are doing your part at the system level by saying, I'm trying to employ teams of healthcare professionals with a common goal, the patient, and trying to figure out how we pay them at some level of salary. But you still have an incentive structure, right? You still have to figure out, how do I reward people for doing more? How do we define doing more? And I think that's where systems, large systems, can actually play around a little bit, because you've got the scale to say, okay, but you have the unique challenge, benefit of having departments and institutes and centers and schools, and good luck, but I'm watching you.
Especially as you begin with your experiment with a vertical integration with a paying arm. That's going to be fascinating. Lots of opportunity to innovate. Yes, any others? We have 2 minutes to go. Yes.
I can be loud, I don't know. Hi, everyone. Adam Colborn from the Academy of Managed Care Pharmacy. I guess my question is for the entire panel, but how do we get physicians on board with some things that might reduce burnout that they currently oppose, like incremental increases in scope of authority for other practitioners? Like the AMA has been firing a lot of shots at pharmacists right now over things like administration of COVID treatments. So, that seems like something if they're worried about burnout, they could theoretically support small changes like that could go a long way to reducing some of those additional burdens.
I think, again, you've got less of these issues in systems where people are added in and you've got a structure to say, just because I add somebody to your team doesn't mean you are worth less or paid less. Where somebody's there to help you. And frankly, we now have data from the pandemic to suggest, okay, how did pharmacists do? They probably did pretty well. I think with physicians, right now their argument is, well, it's a danger to patient safety. Okay, let's actually create some tests of this through CMMI, through state programs, and say, let the pharmacists manage hypertension, let them manage some infectious disease that are test-based in the pharmacy and collect data to see if it actually harms patients.
I think the dynamics change completely when the physicians are employed by a practice or by a hospital system, because in that case, you're actually reducing the work burden of the physician by taking that work to giving to somebody else, right? So talk to a physician at Kaiser Permanente, and you're not going to have the same kind of objection than you do at the place that I work at New York Presbyterian.
Or at WVU.
Right. So I think that's it really, but this goes back to this notion of ending the way that we do things today and shifting to a system on a promised date that Washington will delay.
Yes.
You know, where we move our system to a system in which we have a true value-based system, and where we have, when we move to that system, we're going to have a system in which the clinicians of all kinds, and I mean that word in the broadest possible sense of the word, caregivers of all kinds, are all part of one system. And when that happens, true teamwork takes place, and people are less concerned about task shifting and other such things.
Well, I think we're unfortunately out of time. I've been so excited by this panel. I've learned so much. It is clearly such a multi-layered sort of, the causes are multi-layered and the solutions are multi-layered, and they cross all of these areas that we don't usually think about that have nothing to do with human resources, right? I mean, the human resources people are in their offices thinking about, you know, how many warm bodies are we going to need? But this is about payment policy. This is about trust. This is about new models of care and incentivizing them. So you really need a big lens to be able to think about sort of understanding the causes and the solutions to this issue of workforce burnout. So I'd like to just say thank you to my panel.
Thanks, Polly.
And thank you.